Obviously, it's been a strange and winding road for us in terms of the last year and a half. With over 750,000 deaths in the U.S. alone and trillions of dollars of economic support going to the economy, we all can just hope if we're going to be returning to normal soon. I mean, we thought we were a couple of times so far, but let's assume we are now. Still, while vaccine technology is obviously advanced, along with testing and therapeutics, what else may we have learned from this shared experience? As we all know, the world's becoming smaller and more populated. We need to prepare for the outbreak of the next virus. Are we? What changes or plans must we implement as a society to minimize that impact on our people and on our healthcare system? Ooh, that's weighty. Most of us, when we're talking about these topics, we can only think about being stuck in our apartment and like how much we hated the TV and all of the different hate being thrown around on social media and other aspects. But there are positive lessons we've learned from this, and there are lessons we should have learned from this. And with that, I'd like to bring out our first speaker of the day, Sarah Lynn Mark. Is Sarah Lynn here, or what, are we having difficulties? Well, I'll give a little background on her, and then otherwise we'll just move straight to our doc moderator, and we'll talk about it up front. So Sarah Lynn is an endocrinologist, geriatrician, and women's health specialist. She's been the first senior medical advisor to the Office on Women's Health within the Department of Health and Human Services. She also designed the first Women's Health Fellowship in the U.S. and helped create the National Centers of Leadership in Academic Medicine, Centers of Excellence in Women's Health, and landmark educational campaigns on critical health issues. She currently serves as a medical and scientific policy advisor to the White House, NASA, and other organizations dedicated to improving health on Earth and in space, holding 4 academic appointments, including Yale and King's College London. So as I jokingly said when I introduced Sarah Lynn on social media, is that after 5 minutes of talking to her, I felt like maybe she was dropping names, like name dropping, and then I realized she hadn't even started. Her career has been truly phenomenal. She's been all over different places on policy, but more importantly, she has a very unique view of the policy of around the pandemic and potential things that we might learn from it and what we can do going forward. Sarah Lynn, could you tell us a little bit about what you're working on now, how that applies to our recent experience, and maybe a brief insight on, but give me a positive and a negative that you saw from these past 18 months in policy standpoint.
Yeah, well, thank you so much, Michael, for inviting me. And I also want to thank AngelMD for hosting this session. It's so important. As we know, communication is absolutely critical. I often say that I feel like a broken record because I've been repeating the same messages from the start of the pandemic back in March, 2020. And the key things are that messages need to be clear, they need to be consistent with the facts as we know them, and they need to be coordinated among all messengers. I think when we don't do that, it creates confusion that contributes to polarization, politicization, and even vaccine hesitancy. And as we've seen, it's divided our country. You gave some very sobering numbers, data. Over 780,000 people in the United States have died, 5 million across the globe. We have over 47 million people who have tested positive here. And if you think about 30 to 35% of that group who may even have mild or asymptomatic infection will develop long COVID, meaning chronic COVID for days, weeks, months, and potentially a lifetime, we've got some serious issues to talk about. For me, I have served in many different capacities. You gave a bit of my history. I came to Washington many moons ago to join HHS, and I became the civilian medical advisor to Surgeons General. And at the time, we developed the pandemic preparedness plan, and I always kept it by my desk. We thought it would be bird flu, if you remember that whole issue where we were afraid of avian influenza, and lo and behold, it became coronavirus that would cause so much turmoil for all of us. And over the years, I've just been so fascinated by public health preparedness because I think it's really giving us a snapshot on some of the issues that we need to think about in healthcare in general. And you've raised several of them today, such as the equity issues, the impact of social determinants, such as age, race, sex, gender, all of it, and the intersectionality of all that and how that comes to play. And we certainly have seen that in this pandemic. I am from Colorado, so even though I live in this crazy land of Washington, D.C., I had to go back to my roots in Colorado, and I stood up a task force, a Colorado task force of space tech companies to help companies repurpose their manufacturing to address some of the needs early on in the pandemic. And it was really, so inspiring, so redeeming that people would do this. One of our companies, Andrew Cruz, for example, I'm sure many of you in your audience know Andrew, had offered his canisters to repurpose them for oxygen canisters. So we know that when we bring together committed individuals who really want to help each other, we can raise everybody up. It's a sobering time. I'm going to look back at Colorado right now. I think we learned from case reports. And so let's look at the state of Colorado. It's rising in COVID cases. It's I think it has the 5th highest right now. There isn't a reason exactly why. Can't just be weather, can't just be people aren't vaccinated, because Colorado and certain parts of the state are doing quite well. So how are they addressing this major challenge? And I think, Michael, this comes back to that health decisions are never made against a blank canvas. We know politics, economics, the psychosocial environments shape these decisions. And I think we see this right now, even in Colorado. So what are we going to do? The governor has just issued an executive order to ensure that boosters can be provided to all members of his state, because they believe they're in an emergency state. So again, boosters, are vaccines. The other is ensuring that there are more therapeutics, such as monoclonal antibodies. There's also a point of trying to ensure that people know that they are at potential risk. Now, one of the challenges that I find surprising is that we're not talking about masking. And we know masks can actually decrease spread. There's an amazing study that just recently came out of South Korea that showed masking could decrease the rate of transmission by about 95 to 98%. Yet there's such a political nature around this medical device that we dare not want to even talk about it. And we often leave it to, local and regional levels. So I think, we have a lot we can talk about. We've made progress, but we are no way out of this pandemic. And we can do magical thinking, but we're not quite there.
So, yeah, well, I was hoping you'd tell me all was clear, but I didn't expect it anytime soon. It's like the hope versus expect that thing. You mentioned something that I wanted to ask you a quick question on, and if you could just give a brief response, and then I want to hand off to our doctor host, Kate Eisenberg. You mentioned the pandemic preparedness plan. Now, this has come up a few times where we had a plan. Like, what did we do with it? Just trash it? I mean, what happened in terms of, or did we follow it and it spread a lot faster and it was just bigger than we expected to have, like a bigger effect than we expected?
Well, it's a really, really great question. And I think we heard early on that there were some challenges to the system. In order to have a robust system, you have to fund it. You have to fund it internally, domestically, as well as internationally. I mean, it's a pandemic. It's a global, joint, shared experience. And that comes back to, as long as the virus is anywhere in the world, it's going to be everywhere in the world. So that's why we've got to be united as a global community to do whatever we can to ensure people have access to testing, to vaccines, to therapeutics.
Sure.
What we also have to do, and I think it was mentioned in one of your earlier sessions, is we have to have boots on the ground. We have to have really, really rigorous surveillance. We have changed our ecosystem. Animals are living a lot closer to us that shouldn't be living as close to us. And there is that zoonotic spread from the animal kingdom into the human being, and
sure.
Mutate.
But I'm sorry, but I guess what I'm really trying to get at here is this an issue that we underfunded the plan, that the plan was not followed, or that simply that we needed to test ourselves against an enemy once in order to get the right plan, like meaning that all of the planning in the world, as Mike Tyson, or more educated philosophers would say, everybody's got a plan till they get punched in the nose. Is this just a case we need to get punched in the nose once in order to find out what to do?
I think with any pandemic, we have a window of opportunity. And if you can see these signals, and there were signals, you need to mount your defense quickly, sort of like when the horse is out of the gate, go try to catch it. And so again, coming back to, making sure that you have robust funding, you had surveillance. I think it had gotten weakened over the last few years, and partially because we felt that we had handled H1N1 very well. If you remember that, swine flu. So we I think, got very humbled very quickly here, but we had a window of time. Now, would that have changed the trajectory? I can't say for certain, but I think what it would have done was allowed some communities to scale up so that we could have mitigated death and the disability that we're going to see.
Excellent. Dr. Eisenberg, what do you think from your personal experience of what you saw as things were coming along? Failure of planning, failure of response, not a failure. I mean, there's arguments to be made that we just needed to see one of them in order to figure out what was going on. What's your take on this?
Yeah, I hear you. I feel like most of this was probably predictable. The timing wasn't, but in retrospect, as the pandemic proceeded, there were, lots of word coming out of, oh, this group, that studies zoonoses said it was only a matter of time before something like this happened. And I think we all know that the underfunding of our public health infrastructure, maybe we can get away with it for a certain amount of time, but those gaps became really clear, as things proceeded. And then from my perspective, as a family physician on the ground and as an epidemiologist, early in the pandemic, I knew how this looked like it was going to play out. And it was a very strange place to be because that's not the messaging that was coming out. So there was this real dissonance for me between my own kind of personal synthesis and recommendations and thoughts and what I was seeing in the news and what I was kind of hearing. And so I have a lot of people in my own practice and in my circle and in my health system where I was really the first one to tell them, this is going to be a thing. This is coming. Hey, I bought a Costco membership 3 weeks before anyone else even thought. Like it was, and then I started.
You're the one that took all the toilet paper.
That's right. I personally took all the toilet paper. I did some early research on health disparities. It was very clear to me this is going to exacerbate any existing disparities. So from my perspective, with adequate resourcing and planning, I don't know that it would have gone perfectly, but it could have gone better for sure.
Now, when you say resourcing, I mean, I don't want to, this isn't a political issue, and certainly the response profile has been politicized enough already. But it sounds like from what both of you have said is this was a response function. I mean, Monday morning quarterbacking is always easy, right? So you can always say we should have reacted sooner, except you don't want to react in panic to everything that comes along. Like if we'd shut down the entire economy for H1N1, that would have been an overreaction, right? Or SARS, that would have been an overreaction. Swine flu, that would have been an overreaction. But, swine flu was H1N1. But anyway, the point being that if we'd reacted strongly to each of those, it would have been an overreaction. Here we had a case where we didn't react fast enough, and in reality, we caused a problem. Maybe that's a lesson that we need to learn is what the discerning differentials are between these different signals. With that, I'm actually going to be bringing on some of our panelists and handing it back to you, Kate. I'm going to try to do a group intro so that I don't have to keep talking over our hosts so often. First off will be Mike Raymer. Mike Raymer actually worked with us at AngelMD for a while before heading off to incredibly great pastures at Proficiency, where they do some remarkable modeling and other aspects. Mike has a 25-year experience in the industry, including stints at both Microsoft Health and GE Healthcare. Mike also worked on a project trying to repurpose and revitalize respirators during the height of the medical equipment shortage. We also have Rob Smith. Rob Smith is a tremendous healthcare policy analyst from Capital Alpha. Capital Alpha primarily covers policy analysis and consulting for the Washington, D.C. area. I met these guys when I was working in the hedge fund space. For all the amazing research work that they do in terms of understanding what policy is driving, what's going to pass. Like you want to know whether Build Back Better passes, these guys can tell you ahead of time, a week ahead of time, knowing exactly what's going to go on. Further, you want to know what different types of compensation elements or how things are changing in Medicare space or payables or other things. You know what? If you're an investor in this space, this is the kind of information you probably need to know in order to properly plan your investment cycles. Finally, we have Sean Dufford. Sean Dufford was a frontline commander, so to speak. He was the chief medical officer for, I'm going to get this wrong, whether it's CSL or CLS. Sean, could you give me the organization again? I don't have it in front of me.
SCL Health, Sister Charity of Leavenworth.
It's a charity. Thank you very much. Could you guys turn on your video if you would, if that's possible, if assuming you're not in your underwear or whatever it may be. Give us all a smiling face to communicate with. Thank you very much. And so these guys all have personal experience in their relative spaces. With that, Kate, I'm going to hand it back to you and allow you to have a discourse with these remarkable individuals.
Yeah, absolutely. Well, I'd just love to get everyone's, just to start your brief individual take on the same question that Mike was asking up front. What, how did things go from your perspective and in your different takes on the pandemic in terms of preparation, response, things that you think could be changed for the next time without overhauling things, and maybe things that would require an overhaul. So kind of those initial big picture thoughts. And let's see, Rob, do you want to start?
Sure. Yeah, happy to. Thanks for the question, and thanks to Mike and AngelMD for having me today. I think that Sarah Lynn nailed it. I mean, we had a plan, and we obviously have, agencies that are in charge of being prepared for these types of events. And we were caught flat-footed in a number of ways. And I think one of the issues there is that, we tend to sort of go from, the policymaker perspective, we kind of march from crisis to crisis to crisis. And once a crisis is over, or once an issue has been addressed, we kind of go back to, going about our business, whatever that may be. And then from the congressional standpoint, I mean, we really kind of look at them, I'll put on just sort of lay my DC cynicism out here. I kind of look at Congress like a golden retriever in a room full of tennis balls, kind of waiting for one of them to start bouncing. And until a crisis is imminent and until that ball starts bouncing, they really tend to, just kind of sit there and kind of doze off. So we were caught flat-footed. I think a lot of it had to do with, funding. Public health had really suffered, whether, you look at sort of CDC on the national level or public health agencies at the state level. The Strategic National Stockpile had gone through several rounds of cuts under some of the fiscal austerity we went through and sort of the 2010 through 2018 time period. And really, there just wasn't much of a focus on these types of events. You also have different, views from different administrations. Whereas, the Obama folks, they came in and they were, really focused on some of the more sort of natural disaster aspects of what ASPR, the Secretary for Preparedness under HHS. That they're also in charge of preparing for, and then also, the Strategic National Stockpile. They're really focused more on sort of the natural disaster type aspects. And then the Trump folks, I mean, they came in and it was almost, right at the beginning of the administration when this outbreak started to occur. So I don't think that they had much of their legs under them then. You'd had, several different HHS secretaries at that point. So, I think it was just, poor preparedness all the way through, lack of funding, lack of focus. But I think we have a real opportunity here, while that ball is bouncing, to try to assess what went wrong, what we need to do, how we can better fund these operations going forward.
Absolutely. Thank you. And maybe we can get someone else's take from their perspective living through the pandemic. Sean, would you like to go next?
Sure. I didn't know I was going to be surrounded by so many Coloradoans. So it's almost like this was planned. Like Michael said, I was more front lines, and I'm still doing incident command. And as Sarah Lynn said, we're in the 5th to 7th highest state right now, and we just enacted crisis standards of care for staffing this week, just because we're so overwhelmed. I would say we were, I agree with everything that's been said. We're flat-footed. There's a lot of policies that are made by individuals, somewhat seeming like in a vacuum. But one thing we forgot was Ebola. All that preparation we had around that, in addition to H1N1. And even those didn't, prepare everybody. And I think, everybody kind of thought something was going to happen, but nobody had an idea of how big it was going to be. I think on the positive side, though, was our ability to be a lot more nimble than we'd ever seen ourselves, especially at a healthcare level. Kind of like Sarah Lynn was talking about, seeing different industries. We had Hunter Douglas, the blind company that's based about 2 miles from us, that switched over all of their production to N95s in a very short period of time and stuff. So there's a lot of people that came to our aid. our ability to shift resources around, especially around data. That was the important thing for us to suddenly have the ability to monitor all the event settings and categorize people in case we ended up getting into crisis standards of care and figuring out who would be a candidate for event or not be event. I think one of the most helpful things that we saw in Colorado was the gathering of the chief medical officers and chief clinical officers with the governor on a weekly or biweekly basis through the surge of the pandemic, so that one, we knew that all the healthcare systems were kind of on the same road, not too far ahead, not too far behind, and trying to not hit the guardrails. But that allowed us to make sure that nobody was singled out by the media as doing something that was way out of whack. It also allowed for true operational input into what the governor's office and the Colorado Department of Public Health and Environment were going to enact. We had the opportunity to inform some of those discussions and decisions ahead of time as all the health systems, and we basically had 95% of the hospitals in Colorado represented in those meetings with the governor. So the ability for them to learn and for us to head off a few things, there were still a lot of things that didn't make sense. There's still a lot of gaming between systems. There still are. We enacted our tier 3 of statewide transfer center that takes away the consent of patients to be transferred. So there's a lot of things that are still going on that we've had to figure out. But I think that ability to interact with the policymakers, at least locally, made us probably a little bit more nimble than we would have been. I think the lessons we've learned here will definitely be carried on. I don't know that we're going to need to revamp too much after this, other than to know where the nimbleness comes in, and hopefully we don't get to crisis standards of actual care anytime soon.
Yeah, absolutely. I know I saw that within my own state, New York, and my own health system, is that we were functioning as a unit in a way that there really hadn't been any impetus to before, or, there really wouldn't have been the ability to coordinate across health systems in that way, in terms of data sharing, in terms of coordinating who's getting what care, where, when. And some of that has, been rolled back as it hasn't been as necessary, and some of that is here to stay, and I think in a really good way. And then Michael, could we get your take as well?
Sure. I'm going to kind of start back at 2005 with Sars. So at that point, I was leading global strategy for GE Healthcare, and we saw the event take place in Hong Kong, and we were very concerned. And so in our strategic planning sessions, I brought the lead physician from Hong Kong into the discussions. It's very fascinating to hear how they used both the combination of community health platforms and actually software used to detect crimes and look for patterns to identify what the source, and they had the killer tower in Hong Kong, etc. And what shocked me, we got to the end of it, and I said, well, how much work have you been doing with the CDC? Has the CDC reached out to you? And the answer was no. So here I was with a multinational corporation, non-MD, but I saw the impact that this had and how important that would be to study that incident and understand what its impact may be here in the United States. Yet the policymakers at that point were really asleep at the wheel as it related to SARS. So then you fast forward to the early days of COVID, and of course we all heard about the absence and the lack of ventilators, and Governor Cuomo was indicating they needed 30,000 ventilators allocated to the state of New York. And I actually have been involved in the procurement process for the stockpile of ventilators that were kept at the national level. And one of the odd things in the spec was that the ventilator could not start unless the battery was fully charged, which us in industry said, this is a bad idea, because if these things sit around for a while and they discharge, you could still use the ventilator if it was plugged in to an outlet, but to actually not allow it to boot because of the battery, So when we heard that none of the ventilators worked in the stockpile, every one of us involved in ventilation were like, yeah, we're not surprised at all. And so then we heard that we were going to get General Motors and other companies to manufacture ventilators. So I reached back out to the team. Team I was involved with created the first microprocessor ventilators. And we got on a conference call, and basically we decided to found a startup and a not-for-profit called Covents. And the purpose of Covents was to take all the ventilators that were stashed in closets around healthcare around the country and refurbish those ventilators for use for ventilator hotspots. So we ran that not-for-profit for about a year. We were funded actually by one of the families here in Colorado, gave us the seed capital to go out and acquire the first tranche of ventilators. But we were able to intervene and save thousands of lives while ventilator production was being ramped up by the ventilator manufacturers globally. And it was really a great opportunity. Many of the people on the team had retired. So quite frankly, they were all sitting on the sidelines and very anxious to use the skill sets that they had developed during their career. Today, I work for a clinical trial company that does simulation training. And so we were involved in a number of the vaccine trials. And, one of the things I think we have learned from the pandemic and being now deeply embedded in the clinical trial industry is just the speed at which the vaccines were created. No shortcuts were taken, but really applying those lessons to all the other promising therapeutics coming down the pipeline. So, one is, I think this time it was such a slap in the face. We will learn. We'll study what we did. Two is, we'll be smarter about how to manage a ventilator stockpile. It quite frankly had never had to be tapped in the way that it had to be tapped for this project. I think we've learned our lessons from that. And then third, I'm actively involved today in a number of trials. In almost every one of them, we talk about, how can we safely move this trial at a faster pace? How can we avoid, any kind of deviations on the protocol? How can we better train site investigators? How can we more timely recruit patients? And so that's kind of my holistic view, starting with SARS and then also kind of looking at the vaccine side and in between ventilators.
So let's just, and again, we have 10 minutes here before we have to wrap this up, this session up. So let me just redirect, and I'm going to allow and then toss it back to Kate. Pulling it back together, let's try to focus on a little bit of maybe how have we learned but not implemented, or what we should have learned but really didn't, and what innovative types of things that we could do. How can we engage either innovation or changes in policy or other types of things in order to enact those lessons we should have learned but have not, or don't appear to have? Robbie went off mute, so it seemed like you wanted to jump in on there.
Yeah, no, sure, happy to. No, I like Mike's comments about data and clinical trials. I mean, I think one of the things that's going to come out of this is, the FDA is absolutely awash in real world evidence, because you look at the vaccines, you look at the therapeutics, you look at the diagnostics that have come out under EUAs with very little, they didn't cut corners, but there's a very accelerated timeline. There's at least for the vaccines, there's been very little done on sort of the pre-market clinical side. So a lot of this is going to have to do with post-market monitoring. How do you use data that's collected in EHRs and other sources in a way that's clinically meaningful? So I think that's going to really, that policy, you're going to see that really accelerated. FDA has been kind of working on policies around that over the past several years, stemmed from the 21st Century Cures Act. But this is like a real world, oh my gosh, we have to use this, and we have to use it in a meaningful way, and we have to use it quickly. Also, just to touch on vaccines again, that public-private partnership was something that we haven't, perhaps outside of the military, we haven't really seen used on that scale and with that success. So right now there is a proposal sort of making its way through Congress to have some of that same kind of direct engagement, whether it's through NIH or BARDA, where the government partners with a company directly to try to translate, some of the basic research that's out there now to actual therapeutics, and sort of bridge that 20-year gap that it usually takes in between those products. So I think that was a really great. The vaccines provided a really great sort of proof of concept for that, and that it can work, and the industry can kind of trust the government in some instances anyway to be a good dealer with that. So I'll leave that there so we have time for the other speakers.
And so, Michael, I want to talk about disaggregating data, and I think that may contribute to decreasing vaccine hesitancy. A lot of folks have said, hey, it came too quickly, these vaccines, and as we just stated, the public-private partnership really accelerated the process at quote-unquote warp speed. And again, corners weren't being cut, but the public just needs to be reassured. We have a treasure trove of data, and I think we're at a point now where we can really begin to disaggregate the data by social determinants, which can help lead us more towards precision innovation. And we've started to do that. For example, vaccines for children are at 1/3 the dose right now. So we realize that we can have immunogenicity at that dose with decreased reactogenicity, meaning side effects. And I want to take it perhaps even to the impact of sex. We know women have more robust immune systems. They also have more side effects from these vaccines. The issue of pregnancy certainly complicates it. And I think it would reassure, for example, women if we really looked at the data and saw what is the best dose that can be given in regard to vaccines where you can get the best effect and less side effects. So really taking more of that gendered innovation approach into precision innovation, I think will make a big difference. And again, I'm just going to come back and end with the issue of masking. It's just such a simple tool. It's so cheap. And yet a lot of people are afraid to wear it or it's uncomfortable. And we know masks, for example, do not fit women well. Over 100,000 deaths around the globe are in health professionals, and a significant portion were in women. And if we can redesign masking, our mask, our personal protective equipment, which we also saw during Ebola, I think we'll have great gains. And that leads us, again, into very simple steps towards precision innovation and bringing the public along with us, that we're really looking at their needs.
Absolutely. And Sean, I wonder if we could hear from you as well, and any reaction to thoughts on masking, or kind of, as someone leading a health system, disseminating that type of innovation.
Actually, I'm going to kind of go in a different direction, kind of like based on what Michael had talked about, and that is being fast enough in finding alternatives, because we can't prepare for whatever the next shortage is going to be. And just, simple masking, it took a while for people to convert supply chain and industry to that stuff. I actually hadn't heard of the stuff that you were doing, Michael, with old ventilators and stuff like that. That's interesting because, all we could hear about was, ramping up supply and stuff like that. So if there was one thing I would say would be helpful, would be the nimbleness of manufacturing to come in and help with supplies earlier. Are there other, we had distilleries making hand gel and stuff like that. Obviously pharmaceuticals needing to be regulated kind of limits that, but just the making of glass vials and stuff is sometimes rate limiting for us to be able to get medications. So I think the ability to transfer manufacturing to areas that are truly in need would be something that would be very helpful. Obviously, data is there, but with cybersecurity and everybody trying to make money off of integration, I don't know that we solved that one in the short term.
Let me just throw one thing in there on that, Sean. You mentioned that we did pivot a lot, right? Lots of different industries pivoted to do it. Are you suggesting that we could have done it faster and sooner? And what methodology would you use? I mean, are we saying it should be a government purchasing plan that goes out and says it, or just guaranteed purchase options? Like, how do we do that?
I'm thinking, because obviously when everything's closed down in China, there went our gowns and our gloves and our masks and everything else. I think we weren't fast enough in seeing the private sector. I would, if the government could move faster and could coordinate that stuff, that would be great. But the greatest ability we saw to change came from private industry. And
Right.
I think
Well,
that's
kind of
what's
what I'm
really
getting at. Like,
helpful.
how do we incentivize that private industry change? Like, that's what I saw too. We saw like, college kids who happen to have a 3D printer in their shop printing out like masks for people. We had a lot of different people switching their production lines. You mentioned the distilleries. Like, are we going to expect that the government is going to be more nimble than private industry to incentivize private industry to spin faster? Or do we create is there some other incentivization scheme that we can put into place? So they say, look, when a shortage occurs, we will guarantee X amount of production or that X amount of purchasing from you. So you can then finance a change in production. Like, I'm proposing a financial alternative, right? Where you say if you have a pre-purchase thing, then you can leverage that pre-purchase for funding to switch your production line. That'll give you the security to move.
So, Mike, with the Defense Production Act, that actually helped to do that. And as you saw it, when it was stood up and really energized, it made a big difference.
So Sarah Lynn, yeah, great. You know all about that. Then what could have been done better, or did we do well enough? Like, did that work as intended, or is it just a speed of government issue?
It needed to be accelerated. We had the tool, we had it. We just needed to expand upon it. And once it was, reactivated, it worked. So it's being aware that you have this very powerful mechanism. And, again, it's short term, it's not permanent, but it gives an opportunity to fill in the gaps. As we heard, we had shortages in our supply chain, as we have right now as well.
Yeah, I think the other thing that we're all feeling painfully is just supply chain. And you think about how healthcare systems today acquire products. They're really run through 3 to 4 group purchasing operations here in the U.S. And the reality is they need to put a greater emphasis on supply chain sourcing domestically and be willing to pay a little higher price for the assurity of supply in the event of another pandemic. But just in general, it eliminates the bottlenecks that we're seeing now in Long Beach and other ports and containers around the U.S. as we try to get supplies here. So realize it's not a decision that 5,200 hospitals have to make in the U.S. It quite frankly is a decision that's concentrated in 3 to 4 entities here in the U.S. that need to take the lead on how do we think through supply chain as it relates to the most critical products that healthcare systems need to deliver. I know the surprising thing here in Colorado, I'm very involved with the strategy on the Colorado Dental Association and working with their executive director. And the governor issued a mandate, allowed dentists to start practicing, but no one had any masks for the dentist to practice. And they had asked every dentist to give their masks to healthcare systems to be able to take care of patients. So, the reality is that I find at times some of the policymakers are not grounded in the reality of actually what's happening in the healthcare delivery system. I even experienced that a little bit in Colorado because when I would try to work with the governor's appointed official, they're a politico that had no background in healthcare. So I think that's the other thing we need to be careful about is making sure that the people that we're putting in the most responsible positions for determining public policy in the event of a crisis is to make sure those individuals are well grounded in what actually happens in healthcare and not so worried about the political consequences of the decisions that they make.
Or at least the very fact of putting the processes in place should engage the healthcare professionals themselves in terms of creating the processes that way. I mean, I think most politicos would argue that they did. They just didn't do it enough. They didn't have enough the right individuals. It's like, all right, so this is something we can learn from in terms of a policy aspect. Rob, I'm sure you and I can have a conversation about the reality of Washington, D.C. and whether that's even possible. And I wish all of these conversations could last longer because, frankly, I'm loving it. But unfortunately, as I've had to do with every panel, this too must come to an end. And I want to thank all of you for joining us. And I really hope you join us again for a recap